Nicaragua, but I've been here for most of my life in the United States. I come from City of Hope right now, so I'm the chief of the service in psychiatry. And prior to, well, I've been at City of Hope since just before the pandemic in 2019. But I worked in New York at Sloan Kettering, where I trained as a psycho-oncologist, psychiatrist, and I was there for a while. So I wanted to tell you the truth, I didn't know how much you wanted to hear today. There's so much to know about mental health. And so I usually try to give a little bit of our history, how we seen a psycho-oncologist is very important, and distinguish between different type of psychiatrists as well, with the intention also not only educating, but also decreasing the stigma of mental health that we all have, even including physicians have that. Um, so I'll just explain a little bit, and whatever I did not put in my presentation, you guys can ask me. Like I said, there's a lot to cover, and I prepared, I think, 30 slides, which is usually I do a lot of slides. So I just wanted to start out by asking, how many here are caregivers? Wonderful. And patients? The majority. I started with caregivers because those are the ones that are invisible sometimes to our system. So I appreciate that you guys came here today. As you all know, cancer does not only affect a person, but it affects the whole family, system, etc. At City of Hope, we currently have 5 psychiatrists, 2 psychiatrists that are in the Orange County location, 3 psychiatrists that are here, and we're hiring another one, another psycho-oncologist like me, a nurse practitioner, and we're just blessed with so many social workers. I always say that we can't do this work without the help of social workers. If we had a residency or a fellowship program, we will, I'll give them some attention to them too. But I would say that social workers are the primary force in our system, and then we come after that. I also want to acknowledge my beautiful daughter that is here today, and she's a volunteer at this place, Carla. I don't know where she went. So Carla, it's a pre-med, and she's trying to fall into the steps of mom and dad. Too bad, but that's what she decided. Okay, so so I want to start out by just let me see, how do I minimize this so I can read my slides? So what is psychiatry, right? Psychiatry, you have to go to medical school to be a psychiatrist, unlike psychology. Psychology, they have their PhD, their doctorate in psychology. The way it happened in my career, I always wanted to be a physician, so I became a physician. Initially, I wanted to be an oncologist until my sister got diagnosed with breast cancer. And then I realized that, I had a lot of emotions involved. Unfortunately, she passed away 5 years later. This is back in 2000. So my sister got diagnosed at a time that a lot of medications were coming, but, we have changed so much since then. And, if she were to be diagnosed now, it would be a different story. So initially I wanted to be an oncologist. Then I decided that's not for me. I'm angry with cancer. I don't want to do that. And I ended up falling into surgery for a couple of years. Eventually I moved from surgery because of lifestyle. I didn't want to have my kids seeing a shrink, as I was in my career, and my husband is also a physician. So I decided to go into psychiatry, the opposite of surgery. And apparently there's a big, I guess people change from surgery, they don't go into medicine because it's very different. And there's a lot of people that go into psychiatry. When I was in my residency program, I had the opportunity to see and meet Dr. Mary Jane Massey. I'm just going to throw names out there because I think they deserve to be acknowledged. And she came to our program to give a talk about breast cancer. And I was thinking, what is a psychiatrist doing talking about breast cancer? So that was like 7 years later after, or maybe 9 years later after my sister had passed away. And I listened to her, and of course, the whole time I'm crying. I'm like nonstop. And one of my mentors said, if you want to do CL psychiatrist, which is consultation liaison, you should go into Memorial Sloan Kettering. They have psycho oncology, and I was like, no, I can't do that. I mean, I will be seeing my sister in every patient. So a year goes by, and then Dr. Andy Roth comes and talks about prostate cancer. So at this point, I'm thinking, I can't believe there's such a specialty of a psychiatrist in every cancer. And at that time, I thought he sold me and the whole information. And I applied for the program. And that's how I ended up in psycho-oncology. I can say now that if I look back, I chose the best career, the best profession, the best subspecialty, because it's a combination of not only treating the patient with cancer, but it's also treating, the soul and the mental health. And so since then, it's been my big call. Um, I specialized in breast cancer when I was in my fellowship, and then when I got hired as an attending, I did a lot of bone marrow transplant. So if you think of cancer, breast cancer, or solid organ, and then um, liquid, or what we call blood disorders, they're very different, and they impact similarly and also differently to an individual. Um, Here at City of Hope, I get to see everyone, and so I'm very happy that I'm not so subspecialized, but we are a big cancer and also a big transplant center. So consultation liaison psychiatry, it's one of the many subspecialty of psychiatry. We have other subspecialties like addiction psychiatry, child and adolescent psychiatry, geriatric psychiatry, emergency, and goes on and on, and on, forensic. So consultation liaison is the closest that we can do to practicing medicine and also practicing mental health. So many psychiatrists will go into inpatient because they see patients that have diabetes, that they have other disease like ALS, MS, cancer. Let me close this 1 second. Turn it up. But so consultation liaison is the specialty, psycho-oncology is a subspecialty. So what is psycho-oncology? It's relatively new. When I say relatively new, it's in the 1970s. So, and it basically is a new interdisciplinary field that addresses psychosocial issues, provides support for patients, loved ones, families, friends, community, etc. It's composed of dedicated professionals, people that really want to work with cancer patients. So I feel that if I had never been trained in my field, working as a general psychiatrist will be very difficult to sit down with somebody that has cancer. And so we have within psycho-oncology, we have psychologists, social workers, we have neuropsychologists that work on how the cancer treatment or the disease impacts the cognition of an individual, chaplains, etc. It's again, it's a subspecialty of consultation liaison, and we are trained in different psychotherapies that are outside the regular therapy, like CBT, behavioral. So we do more of what I will mention later. And unfortunately, if I knew that I was going to have an hour and a half, I would have brought more on this type of psychotherapy. But we have meaning-centered psychotherapy that is based on Viktor Frankl's reading of Men's Search for Meaning. And meaning-centered psychotherapy, it just focuses on existential distress. And it's a great psychotherapy that we use a manualized approach. We have dignity therapy, which is it's more at the end of life that we use. And then we have family grief and other stuff that we've been adopting in the field of the oncology. I will speak very clearly, and I will mention maybe things but with no intentions of getting you upset, but we cannot deny it and ignore the big elephant in the room when we get diagnosed with cancer, right? Which is the fear of dying, the fear of not being treated. So if I mention these things here and there, it's not with any intention to get you upset, okay? Or you guys can raise your hand and say, can you just move on? Because I understand it. But the training of psycho-oncology as a subspecialty, it can be a year long or it can be a 6 months. Right now, Stanford just opened up one position for a track for psycho-oncology, and there's 6 months in training with patients that are dealing with cancer. In my training, it was like 9 months, 1 month of vacation, and then 2 months of regular psychiatry. And so we understand, or we try to stay updated with medication, with treatment, how the treatment impacts your mental health, your physical health, etc. And the reason is that by knowing with all these new medications that are coming out every year, I mean, every month we have something new, we try to keep up and learn from our colleagues as well. We understand how cancer can impact your life in so many different ways. We try to use medications that help with physical symptoms, and we just don't treat depression like, oh, you have depression, no, or you have anxiety. So we try to be very, very good about using a medication that it will help different symptoms. And I will give you some examples. Do you need water? You have water? Okay, good. And basically, we have sometimes patients that come in with premorbid psychiatric disorders, right? Like, for example, we might have somebody that is dealing with bipolar disorder or has had a history of bipolar disorder or a history of major depressive disorder, panic attacks, anxiety. And then on that, on top of that, you're compounded by the disease. So it can be somebody with no mental illness or history of mental diagnosis, or people that come with other diagnoses like schizophrenia. So it's not that I try to sell my product to my patients, but I always tell them, you need an advocate here, somebody that can speak up on your behalf, and also to treat and understand you and go through the whole journey with cancer with us. We see all these different disorders that I mentioned there, management of, in an acute setting like delirium. So hopefully none of you have been hospitalized before, but sometimes you come into the hospital because you're sick. And just an infection can cause a state of confusion that we call delirium. And delirium can present like with periods of being completely with it, and other periods of being disoriented, seeing things, hearing things, agitation. And unfortunately, some of our patients that are in the ICU that developed this delirium can also present and develop some PTSD. And so it's PTSD is post-traumatic stress disorder. Sometimes you just imagine being in the ICU and you're agitated, and they put straps on your hands and you're just trying to get up, and your brain is making stories out of what is happening, and maybe your brain is completely disconnected with reality. But when you leave the hospital, you remember things. You remember that somebody was trying to hurt you. Or maybe I have a history of PTSD because I've been sexually abused in the past, and I come here and I'm attached, and the first thing is going to be my brain, bringing all those stories from the past and put it into a huge story when you are in the ICU. So there's the part, and also when you become a patient, they're not asking you, do you have PTSD? Do you have a history of trauma? Maybe they do, but some of us do, but some of us don't want to talk about it, right? And then you get hospitalized. So most recently, I had a patient that it was from Central America with a history of being, with trauma from the war. And he comes to the hospital, and the first thing that he says to me, I have to be facing the door because I can't give my back to the door. And of course, I ask the questions, and it happens that he has some history of trauma. So patients bring, like we all bring we inherit all the legacy from our parents and some baggage and stuff. When we come to the hospital, we get sick, we are in a different state and we are very vulnerable. So all those things, if you are not treating patients with cancer, I think it would be very hard for me to, to approach a patient and say, let's talk about cancer or how you feel. So far, so good. I'm not okay. I can get carried away with this. Um, and like I said, it's a psych oncologist. That's a the subspecialty. We do. We talk about from the beginning of cancer until the end, and we also teach how to provide or deliver bad news or serious news. We used to call them bad news. Now they call them more serious news to patients. And if you're in a good setting, you talk to all your colleagues and we talk about cases, right? Because it's normal that I'm going to have countertransference, what we call like the reactions of that my patient will cause in me, or the feelings that I will develop when I'm with a patient. So we talk about those things. And when we lose our patients, we are not expected to just, just put it on the side and keep on going. We talk about our grief and losses as well. We also run support groups for that as well, for our colleagues. So the importance of seeking mental health support. So I'm seeing here that we are from different backgrounds, right? I don't see Latinos, but maybe, well, I am. Oh, you are too. Oh, there you go. Well, where are you from? What is your background? Yeah, your ancestors, your Mexico. Mexico? Okay, and I'm Nicaragua, right? So even in all Latin America, every country has their own culture. Yeah, we all speak Spanish and we all share similar, culture from our Spaniards, but we all have different cultures. Same as in Asia, right? So what is your background? Do you mind if I ask those questions? Hong Kong, the same. Oh, China, okay. Beautiful. So we have a different, but so you can imagine if I'm talking to somebody from China or Japan or Korea, do you think the approach will be the same? So we try to be very culturally sensitive and focused, and at times I tell my patients, like, even if I have an interpreter, I try to, look at my patient. I'm always telling them that I wish I could speak the language, but this person in the background is providing the translation. So everyone has a different belief. Yes, ma'am.
I was just saying, this is California, so Thanksgiving, my family has African American, Mexican, Korean at our table. Between my in-laws and
That's great.
My son-in-laws, brothers-in-law, etc.
Yeah, and in New York, it's even a bigger melting pot, right? So I yeah, but can you imagine what you do in mental health and understanding what your parents believe about you seeing a psychiatrist or you going to, or why did you get cancer? There's still that belief that you inherited cancer. A patient just told me that my cancer jumped from my son to me. And I was like, what do you mean it jumped? She said, well, doctor, that's not what I meant. But I have another patient that her sister called her and said, because I've been hanging out with you, now I have cancer. I mean, so you still hear those things. Yes, ma'am. Oh, right. So yes, ma'am.
And then they got wanted to know what their
Ancestry was.
health part too.
Yeah. Okay.
So I asked their parents, can I pay for it so they can get it? And they said yes. So the only one left, and we know a lot about him. He's American Indian, but if he asks, then we'll get it because it helps to know
what genetic predisposition they have. I mean,
I'm gonna get something else, When they my sister specialist said, this has gotta be genetic. It's psychoability.
okay.
And I did mine, I have more genetic defects than they did. I have two, they only have one, and they were in the hospital with intensive care with.
Oh, with bees. Okay.
Yeah, so I thought I did mine after.
Now you're like super vigilant, hyper vigilant.
But no, I'm on medication.
Okay. Well, that includes that too, the treatment. Um, any other questions so far? Mm-hmm. We still listen. Then everyone that is in jail, like, or people that hurt other people, they would be right. And we always said, it's like, when people say that, well, I was told that is that, and I said, what about the children? Karma do they have, right? Unless you are Buddhist and you believe in the reincarnation, that's different. Um, so yes.
I wonder if you have any study that shows, like, what's the percentage of people having psychiatric issues like depression or whatever, and then later they were diagnosed with cancer, and vice versa. They have cancer and then they're depressed or something. What is the percentage? I know it's probably related in some way.
How would depression will be related with cancer?
Depression, I think depression affects you
Immune system,
emotionally,
immune system.
immune system. You can sleep well, you don't eat well,
And so that's
you
it's
have
just
social life,
right.
and all that I think impact your immunity, your
I,
could impact your
sure,
cancer.
and I can look into that, but I will tell you that historically, that was one of the thoughts. You're one of the thoughts of like, oh, you have cancer because you have a lot of stress, or you have cancer. Stress causes cancer, depression causes cancer. Being having, starting to have sex at a younger age, oh, that could cause vaginal cancer. So there's a lot of beliefs, and I will have to look because I see it the opposite. I see some cancers have depression, and it's sometimes the depression it's diagnosed before the diagnosis of cancer. So, but I can look into that. Yes.
I used to be a hospice. I was at the palliative care nurse in office.
Oh,
I said the
fun.
patient is depressed, and they said, of course, they're sick. And I said, you can treat depression.
Right.
No, what do you mean? Of course they're sick. I want my patient treated.
Yes. Well, thank you for all the work that you did. So as we know, we get more people diagnosed with cancer, and because, thank goodness, because of the treatment that we are getting, we have a high number of survivors, right? But treating cancer and curing cancer doesn't mean that you're done. But a lot of family members think it's like, oh yeah, you're supposed to go back to work. You're supposed to be the person cooking, doing all that stuff, or the man has to go back to work and bring the money. So unfortunately, it comes in the middle of when you're having the best time in your life, and you're having plans, and interrupts your life, and just imagine trying to pick up all those fragments after. It's very difficult. So because of all this experience, of all the new treatments, we having more patients with improved, increased survival rates, but at the same time, we have other comorbidities and other symptoms. And distress is like includes depression, anxiety, all the suffering. Yeah, so cancer, as you all know, and you understand better than I do, it can present at any time. Just going to college, just getting married, just having your child. I just had a young lady that was diagnosed after her baby was born. She's 30 years old and is already metastatic. So it just can present at any time. It doesn't have any interest in how much money you have, or if you're pretty, or if you're ugly, or if you're, whatever. It presents at any age too, right? We have little kids that are diagnosed with cancer. And this can be very traumatizing for the patient and the family as well. So this is the typical trajectory that we talk about the illness, right? some people that have a history of like family members that have cancer, that you're trying to focus so much on being so healthy and avoid doing this. So lifestyle, nutrition, there's like a, you're pressured because you're afraid that you could inherit the same cancer. The cancer screening, just even going to a colonoscopy, or because your father died of colon cancer or your brother that has colon cancer, it causes a lot of distress and anxiety. Mammograms, my sister passed away at the age of 30 and she was diagnosed at 26. So ever since then, I've been doing mammograms. So some people manage it better, but other people feel like distress every time. It's like there's a little lesion there, there's the anxiety goes up. And then it goes into you're diagnosed and you are in this stage of like looking for the right person, doing the treatment. Everything seems like very cloudy, overwhelming. You don't understand anything that the doctor is telling you. So I always tell my patients, always go with somebody and with a little note like you, just taking notes, because you come out of the room and you will forget everything that they said. And so the focus on in oncologists is a curative treatment. Unfortunately, some of them come back, and then it becomes a chronic, instead of life prolonging intent, I call it like the chronic cancer. I have patients stage 4 that have 12 years with stage 4. Before we didn't have that. And then there's the palliative side, when the treatment is not working anymore. We try to educate our oncologists that palliative treatment should start from the time you get treatment, because palliative doesn't mean dying necessarily. And I will tell you a little bit about the founder of the palliative movement that you might know about her. And but it also helps with in the moment of like, do I have nausea? Do I have fatigue? Do I have pain? How am I going to deal with the pain? Pain can interfere with treatment. Pain can make you feel depressed, can make you feel hopeless, right? Because you can't live in pain. The majority of our patients that say that they want to die or that they're suicidal is because they're suffering from a physical ailment, or maybe because of the news that they received they were delivered in such a, not in a nice way. There's always this, just living with the uncertainty of the disease, the fear of recurrence. You guys are aware of that and know it better than we do, and the emotional and psychological impact. So before, cancer was perceived as death. That's a death sentence. In some cultures, still the same, either because they don't have the treatments that we're so lucky in the United States that we have this treatment, right? And if somebody, and we see it in our culture as Latino, it's like somebody got diagnosed with cancer, oh my God, they're dying. They don't even know stage 1, if it's 2 or what kind, it just automatically connected with death. So it is perceived as a death sentence, but it's thanks to all the treatment, new treatments, thankfully that's not necessarily the case. Well, we talked about the psychological distress associated with cancer. One thing that I want to mention, the loss of identity and self and grief, is something that we don't talk about. Women with a mastectomy, and how they will say, yeah, well, you see me with a blouse, but you don't see that I have a prosthesis, or some women, they prefer not to have an implant, right? But every time a woman looks at themselves in the mirror after a surgery, that's a constant reminder of the breast cancer. Yes. When a man, has a stoma, or a woman that has a stoma, nobody sees it, but they have colorectal cancer maybe, and they have a bag, and the shame associated with that, the fear of, am I going to have an accident? The smell, is it going to blow up? All this, it's constantly with you. So that, what we call it, the loss of identity, or the grief that you are, that you quietly dealing with. I was thinking, so those we can hide, right? What about head and neck? Head and neck cancer, you can't hide from head and neck. If you have a surgery, and somebody's not swallowing because they cut half of the tongue, or they did a surgery, it's always there. So just be mindful that, well, I shouldn't say be mindful, because I'm not talking to a population that is not aware, but those are the things that we think about. We were talking about depression. You said how many people have depression that turn into cancer. There has been a literature for a long time about pancreatic cancer and depression. Depression, sometimes we see on pancreatic cancer because of all these interleukins and inflammatory markers that are running before they get diagnosed. Now there's more an argument that no, it just comes about the same, or it could be after. So some are associated with depression before you get diagnosed. Part of the history is how do we get it to become more focused on psycho-oncology? How did this movement start? Because I think it's important to know. And I love all these mentors that we had in the past. So for centuries, the old fears that negative attitudes will cause cancer. The stigma toward mental illness is like, are you crazy? I'm not coming to see you. I'm not crazy. I'm like, well, we are a little bit, if you want to put it that way. But it's like usually you need somebody that a space that they can listen to, that you can be listened to, somebody that you can kind of like unload all the grief, all the pain, all the depression, all the sadness, because at home you don't want to do that. And a lot of us, are holding on to our feelings and we don't talk about it at home, or we don't have the space because my husband or my caregiver might say, it's like, you know what, I don't want to hear about it. Everything, you have to be positive. You have to do everything possible. You're not positive enough. And so we provide the space. And so I tell my patients, when you come to see me, it's not only about medication. Just find it a space. Don't worry about me. Just unload everything that you want to unload. And I think that is very helpful. Yes, my dear.
How does that affect you?
Oh, I will tell you about it later. Yes, so we all get, we all get affected. I cry when I have to cry. I mean, I don't do it about me, but if my patient is crying and a tear comes, I'm trying to hold it together. But if it happens, it happens because we're human. I have gone to funerals in the past, but what I did, so in psychiatry, we always keep boundaries, and boundaries are very important because of the mental illness, because of personality disorders. Unfortunately, in psycho-oncology, we loosen those boundaries sometimes to an extreme. So that's why it's good to have a mentor where you can talk about it and say, like, check in, like, I'm going to a funeral. Can I talk about why am I going to a funeral? So the first time I went to a funeral, I asked my mentor, and my mentor said, you don't have to ask me. You go because you need to go. And sometimes it's for my own closure of seeing my patient for the lab, for paying respect, or for the family members to see that maybe one of their doctors showed up, at the end. But I set boundaries when I was with my kids, and I used to say Saturday. I mean, if I can do it after work, or I had like sometimes, in New York, it's getting to certain areas, it can be easy or too far. But so I had boundaries that it was when I had to be with my kids, I couldn't, but if my kids had something, then I will try to go my best. So you develop some tools to how to deal with this and cope, and I'm still learning, but I will tell you more about how I'm learning. So the psychosomatic movement impact, basically, it's just like back then, nobody cared about that. Nobody, research in psychiatry or mental health was considered like a soft science. So it's like, why are we going to do that? There's no biometrics. There's no, studies that have been done. But in the 60s, they started doing it with breast cancer. So some of the impact of patients and attitude, we're going back to, yes.
Seems like there are some, you have childhood conflict.
Oh, so that was back in the days before that they thought childhood conflicts can lead to abnormal cells.
Oh.
So this is what we thought about. So I don't think so, but I mean, back then it was psychoanalysis, right? We didn't have, and then psychodynamic, and so these are things that were before psychosomatic movement. So I'm sorry that the slides can be confusing. Thank you for calling that attention. But certain personalities, narcissistic or borderline, they can lead to some cancers.
And they used to say like type A personality,
Yeah.
most of them get cancer.
And the whole New York, a lot of community will do that. Grief and stress can cause cancer. So these were thoughts.
Stress kills you? I do think so.
Well, stress can affect some, your health in many ways. Blood pressure,
Everything.
heart attacks. I mean, it can be. But before there was that connection. The cancer was caused by all these things. That's what I meant.
All this exposure.
Well, that's what we used to think. We're far away from that now. So the other thing is, it was like the impact on patients' attitudes. It's like you gotta, and I do some of those visualization for immune cells killing, cancer cells. So some things I use because it's just causes, it decreases the anxiety. Like when somebody's gonna have a transplant and they're telling me like, oh my God, these cells, it's more CBT. Like if they're saying these cells are coming in and I'm gonna feel like I'm gonna die or something. I would try to reframe of what the cells can, how to see those cells so that you don't feel that anxious. But there's other things that people say, well, you maybe wanted to have cancer, so I think the slides, I kind of like connected a little bit, but I shouldn't have connected because.
So you don't think any of this is?
So I think there's a mind and yeah, there's a connection.
Yeah.
But this was more in the context of the cancer. Like if you think of something, you're gonna have cancer. Yes. Maybe I should have just. Or depression will make your tumor growth. I think the one that visualized your immune cells killing cancer cells didn't belong to this slide. Remember Jackie Onassis, right? When she got diagnosed, it was like, this poor woman has gone through so much. She got her cancer, her breast cancer. So that was all in the news back in the days. So we still believing. So this is in the past. We still believing that tragedy can cause cancer. So these three women, that's part of the history. We have Dr. Cicely Saunders. She was the mother of palliative care, the palliative care movement. She was a social worker, became a nurse, and then went to medical school, just to have some influence in the palliative world. And it was pain. You have to palliate pain. So she started treating more the pain than anyone else. Elizabeth Kubler-Ross, if in high school, college, the 5 stages of denial, acceptance. She wrote and she started working with patients that were dying. And she wrote all her books, the final stages of growth, on death and dying. And this lady over here, this is the one that I would like to focus because she was a psycho-oncologist. So she's a mother of psycho-oncology, was my mentor. I trained under her. So every presentation I have to put her in my presentations because thanks to her, we are doing what we do. And she wrote the book, The Human Side of Cancer. And it's also in Spanish and English and maybe many other languages. So Cicely Saunders was the one that understood the complexities of dying and the nature of suffering. And she always said that while the human body has a capacity to suffer, so too does the human psychic and the human spirit. And no matter, because you are you matter to the last moment of your life, and we will do all we can to help you, not only to die peacefully, but also to live until you die. So huge influencer, and she was connected with the same women, with the other two women. This is Elizabeth Kubler-Ross. And when we talk about the stages of dealing with death, denial can come at any time. It doesn't have to come in the moment. You get a bad news and it's so much to process and there's so much to adjust. So someone that just get diagnosed doesn't mean that you are depressed in the moment. Oh, you're depressed because you got diagnosed. No, no, depression is a different thing. This is a bomb that was thrown in your backyard, and now you have to deal with this, and it's going to take a long time to adjust and to understand if you are able to make sense out of this. And the acceptance, can come before death, can come at the beginning, depending on what tools do you have. So Jimmy Holland, it's an interesting story because I have the time, I'll say. She was one of the few women that went to medical school back in the day. She was from Texas, the only child, raised in a farm. Her parents were drop out of high school. And unfortunately, after she went to medical school, her first husband she met in residency, and he killed himself to suicide. And then after that, she decided to go into psychiatry. She married James Holland, who was one of the pioneers in chemotherapy, started using not only one chemotherapy, but two chemotherapy at the same time. So back in the days in Boston, they used to come and talk about patients and cases in their living rooms. And so she used to be in the background hearing all these guys talking about, oh, we have the new treatment for Hodgkin's or leukemia. And so one day she opened her mouth, she said that. And then she said, and she asked a group of men, have you ever asked a cancer patient, how do they feel? How do you feel? And they were looking at her like, she said, it was like, I had three heads. And they were like, what? What do you feel about the chemo? No, how do they feel about the cancer? And that was the question that started our field. So later on, Jimmy became like the tireless advocate for cancer for women. She's so well known in the world. She went to China. She went at the age of 85. She was in Russia. She went to Kenya. Now we have a group, the IPOS, the International Psycho-Oncology Society. So every country where you come from, if it's besides the United States, we have psycho-oncology. It's just that it's not well even recognized. And then we have the American Psycho-Oncology Society, and she founded both of them. And the most important thing that she did, besides being the pioneer, is that in the NCCN guidelines, NCCN is the National Cancer Network. She was able to create to add distress in the distress thermometer as a sixth vital sign. So we had pulse, respiration, high blood pressure, blood pressure, temperature, pain, that was started by Cicely, and then distress. So now we do distress thermometer. We use it for research. We use it to a lot of cancer centers use it just to identify what causes distress. I'm part of the committee, so every year we include something else. And
this is just for City of Hope.
oh, this is oncology. In medicine, we have the 4 vital signs and then 5 vital signs. Now the sixth. The sixth.
The ER.
No, the sixth. It's the stress associated with cancer. Good questions. So this brings me into psychopharmacology and psychotherapy. And I do this so that you have a little of understanding of why you should ask more questions when somebody prescribes you with an antidepressant. And so let's start with an SSRI. Before that, to qualify as depression, you have to have at least 2 weeks of most of days feeling depressed, or having 5 symptoms of depression, like you feel isolated, or you are isolated, hopeless, helpless, worthless, suicidal, not wanting to leave. It's different. Feeling fatigue, you feeling your concentration is poor, you have no interest in doing the things that you enjoyed. But if you have cancer, you're on treatment, you have fatigue, your memory sucks, right? your insomnia, you have trouble sleeping, or you're sleeping too much. So those three, or lack of concentration because you have you're just getting chemo and you're not feeling yourself, or you're a woman that unfortunately you went into menopause and everything is menopause, right? So those symptoms do not count as depression. But you look at them and you said, well, I'm cognizant that I have these symptoms. Doesn't necessarily mean I'm depressed. You could have adjustment disorder, which is you adjusting to the news or adjusting to whatever is happening with depression or anxiety. But let's say put all that on the side and say, well, I am depressed. I feel miserable every day. I feel sad. I feel like there's no purpose in life. I've lost purpose. I have no interest, and nothing makes me happy. So then what I do with my patients is like, let's see if depression runs in your family, because it can be that your depression has been compounded by the diagnosis, right? So I would say, yeah, it runs in my family. My mom is depressed, my sister is depressed, everybody has been on depression, on antidepressant. And I just happen to be that I feel at times depressed. But now I have this disease and this diagnosis, and I just feel terrible. So one of the things that I will ask is, what medication are they taking? Because sometimes whatever works for your sister might work for you. And so they tell me that. Or or maybe they took antidepressant before, but they developed that side effect and they only took it for 2 days and it doesn't work. So we try to, go back and say, how long did you take the medication? What were the side effects? Let's try. Every medication has side effects. Aspirin has side effects. Levothyroxine for your thyroid has side effects. Everything has side effects. So what I do is educate. These are the 5 antidepressants that from SSRIs that work in the serotonin in the brain. And they offer anxiety, depression, PTSD, panic disorder, OCD. Some work better for certain things than others. So we will try to choose which one works best. So if I have anxiety and I'm depressed, or I'm older and I have a heart condition, I look at the studies that they've done, and all of this a nice medication. It doesn't impact a lot. The side effects are mild, but there are more studies on that. So I would choose something that fits yourself. So it has to be very individualized, rather than just like, let's try all of them. And I always start with the craziest dose. Like I tell them it's a baby dose, and I really mean it. If Zoloft is 25, I'm going to start with 12.5. And it's not because I want to do it or trick you, but it's just to kind of like make sure that your side effects are not so, the side effects that you might not like, and then it's more about adherence than anything else. And then I said in 5 days, you just go up to the minimum dose, which is 25. Same with Lexapro, 5 milligrams. The initial dose is 10. I start with 5. And if you feel like, oh, I feel a little bit weird with that, okay, cut it in half. I don't care what you do. But you start taking it, and then your body gets used to it. A lot of the side effects we connected with the stigma, right? That antidepressants will cause all this or whatever you heard other people saying. But the best thing that I've seen is how patients are feeling depressed, and all of a sudden they take an antidepressant that works, and they go, oh my God, I should have done it a long time ago. I feel lifted. I feel connected with life. I feel, life has purpose. It's just the dark cloud is gone. That is the most amazing feeling. And with anxiety, same thing. I'm anxious. I can't function. I can't sleep. I'm always, like, ready to jump or whatever it is. You get a little bit, and you don't have to be ultimately medicated to feel blunted, because some people will say, oh, I feel flat. Yeah, but I mean, it's just some medication like Prozac can do that, or Lexapro can do that if you fall into that category. So these are the SSRIs. This is the one that we start before anything. Now, knowing what treatment you have is important to me, because I'm going to put the new medication with all your medications to check for interactions. Some medications can increase treatment, some medication can decrease treatment. Tamoxifen is known for that. So with tamoxifen, I choose not to take one because it could decrease the metabolite of the tamoxifen, or or it can increase like, something in lame terms, QTC, the prolongation in the heart rate. Or I can think of, I don't know right now. But I will be using a different one. And yes,
Does any of these medicine does it affect your cognitive ability or the cause negative impact on dementia?
no, it's not associated with that. But I will tell you what I tell my patients too is like, you come in with that, this is stress. You didn't have depression before. Let's do it for now. Why would you, it's another tool just to cope, make you cope with help you to cope with this disease, or also side effects, because some of our cancer drugs can cause depression. Just, aromatase inhibitors, exemestane, letrozole, tamoxifen, they can, I mean, it's not only depression, causes bone pain, it has other symptoms, right? Hot flashes. So I choose the medication depending on the side effect that you have. So I'm not selling a drug, but I'm saying let's use a medication that helps with the side effects so that you continued with your medication. And if that makes you feel better, great, or just during this time that is very difficult. Once you go into survivorship, once you feel that accepting the disease, whatever it is, then we can start pulling back. So it's about just helping you get through the whole thing. Yes. So we have so I will go to SNRIs. SNRIs are the ones we use. Cymbalta. Maybe many of you have heard Cymbalta for neuropathy. You have neuropathy because some chemo causes neuropathy. Cymbalta helps with that. So if you have bone pain, maybe Cymbalta might be the best one. But venlafaxine is the effects is like the one that we start out with when somebody's on tamoxifen, because most of the studies were done on venlafaxine. But now we can use for tamoxifen, we can use Lexapro, any of the SSRIs, and I'm sorry, there was a study on Zoloft that will prevent the efficacy of tamoxifen. I have to review it because then they started providing also Zoloft to patients. So we do Effexor because of the hot flashes, it helps, but Lexapro also helps. The ones that we don't use, it's Prozac with tamoxifen. And it's too confusing, but it's like every medication is metabolized by an enzyme that is produced by the liver. So some medications can increase in cause toxicity, and some medications can decrease the efficacy of the medication, or they can accelerate the metabolism. So we look at all those. Yes, ma'am. Sorry. Mm-hmm. Yes. Oh, I'll tell you some side effects. Yes. So I will tell you the side effects because I put them on purpose, that the most common side effects. I mean, the side effects can be like a whole page of things based on little percentages. Um, these are other medications. These are other medications that we use if you, let's say, you say, I don't want to gain weight. I'm already gaining a lot of weight. I'm more cognitively slow. My libido, it sucks, So we think, okay, so if you're bless you, if you're in an SSRI or SNRI, the ones that I showed, sometimes giving a little bit of bupropion can improve with the libido, and because it works in the dopamine center and norepinephrine, and it's just different than an SSRI. So we use a little bit, and people say, oh, it helped. Mirtazapine, Remeron. If you're losing weight, you can't keep your weight, your appetite is low, you can't sleep, mirtazapine might be the best medication. So we always try to use the medication depending on all the symptoms that you're having. But if you don't want to gain weight, why would I give you mirtazapine? It will be like a punishment, right? What do you mean? You want to know? So Wellbutrin doesn't make you lose weight, but it's more activating. It's more a stimulant. Trazodone it's an antidepressant that we only use it for sleep. So it's good because we're using an elderly that, we're afraid of the balance. And so you start with 50 milligrams, 75. Some people work on 150. You take it as needed. It's not an addicting like benzos, or Ambien, but we use it for that. Buspar is I don't use it as much, but some doctors do, and it's for anxiety. Um, Benzodiazepine. So when we are treating depression and anxiety, what I always say is if you have anxiety, I'm not going to wait. I'm not going to let you wait in 3 weeks because it takes about 3 weeks for an antidepressant to kick in. So in the meantime, if you're anxious, I'm going to give you a small dose of, lorazepam, alprazolam, or whatever it is. Alprazolam, Xanax, it's primary cares love it, but then you get hooked with alprazolam and then you can't live without Xanax. So psychiatrists don't like Xanax because it's only for panic attacks. And if you use it, and it has a short half-life, so you take it at 8, at maybe 12, you need another one. And then you become addicted and you start increasing and it's hard to get off that. But it's a great medication for panic attack. I mean, if you look at Xanax, it tells you all anxiety, all insomnia, all the stuff, but we use it for panic attack. And if I have a patient that has some respiratory distress and I don't want to make him feel too sedated, then lorazepam might be too sedating, so I will use a little bit of Xanax because it doesn't, if you're driving, you have a panic attack, you take Xanax and you don't fall asleep. So I use it for patients that I'm concerned that they will fall asleep and they're having some, respiratory distress in the hospital. Clonazepam, it's a longer acting. Yes.
Sorry.
No, it's okay.
I was just curious, okay, so you start with your regular oncologist, and then at some point when your regular meds or whatever, then they will refer them to you.
So you can say that I need help, I need somebody, or if they start noticing that you're depressed, they will talk about it to you.
Do they ever consider integrative oncologist or functional, natural?
Oh, they do have that
first. How, because it just seems like one drug leads to another, and what if you want to?
So integrated medicine is a different. It's a different, right?
Do they try to get you to maybe deal with symptoms a different way first, or
for depression? Integrated medicine, I'm very I mean, I don't think an integrated medication might help with deep depression. It can help for some anxiety. It can help for insomnia.
Right.
Yeah, but I mean, so I have in our group, we have an integrative psychiatrist, that right now we actually have a study going on for L-theanine, that is for to help women, men, anybody that has completed treatment, to see how much the anxiety and insomnia is helpful. So we have that study going on at City of Hope. This is focused. I mean, I didn't touch any on integrative because
it's just curious, how it goes from regular oncology to
You can ask, no, you can ask if a center, let's say if you go to City of Hope, we have an integrative. Okay, so with Mortimer, you can ask and say, Dr. Lee is the only integrative oncology, but because, huge, because everybody wants to do that, right?
And I'm wondering if I think Lisa Connolly.
Oh, I love her.
Right, but it was hard. It's hard to get an appointment with it's very hard. I mean, it's a very sought after field. But it's hard.
But it's also because it just new at City of Hope, and we are so lucky. Panda Express gave so much money for us to open up the integrative oncology. It's only one, I think, 2 integrative doctors. They're always hiring. Our psychiatrist just does a little bit of that. We do some little studies, but they have massage therapists. But it's a small program. It's just starting. So you can imagine you put this, and it's like a tease because everybody wants it. I want acupuncture. Exactly. So, but it's so it takes a while, and but I hope it continues to grow. So yeah, but I mention all these medications because if you ever hear about melatonin, I always take a little melatonin. It doesn't work for me, but it might work for you. It works great for my mother. Quetiapine, olanzapine, those are neuroleptics, antipsychotic that we use in the hospital, but we also use them when you are on steroids So if part of your treatment is steroids, then you're going to be manic. You get a little psychotic at times. You can be, and if you have bipolar disorder, oh my gosh, then we got to get in before you flip into mania. But steroids are great medication for anti-inflammatory and for and for leukemias, and it's part of dexamethasone that you take before you take your chemo. It helps with nausea. So we try to use Zyprexa, which is olanzapine, to help with that, to kind of like stabilize a little bit the effect. And then the other stuff, just mention it because gabapentin is for neuropathy. Depakote is a mood stabilizer that we use. Lamictal, another mood stabilizer for bipolar disorder. And these are the common side effects. Oh, she left. So we have the common side effects are like either you fall into somnolence or insomnia. So if I take Lexapro 5 milligrams in the morning, I feel sleepy, I'll just say, just switch it to the night because you just happen to be having that side effect. But if you take it at night and you're like so activated, it's like, no, you got to switch it to the morning. Nausea, the majority, some Zoloft, unfortunately, people get very nauseous at the beginning, and that's why we start baby steps, like baby doses, but it's a great medication for OCD, anxiety, and depression. Not too much weight gain, but Lexapro can cause weight gain. Prozac, not as much, but you can fall into that part, that person that might gain weight. All SSRIs, when we have low platelets under 30, we are very cautious about it because it's like an aspirin. It could, increase the rate of the tendencies to bleeding. And Venlafaxine, Cymbalta, and Pristic are the SNRIs they work in the serotonin norepinephrine. If you stop the medication cold turkey, you're going to have discontinuation syndrome. So just be mindful that sometimes you have to be like titrated very slowly. You feel like you're having a flu. Sometimes they say brain zaps. And it's very uncomfortable. But so if you're taking 120, you got to go to 90 for a couple of weeks, 60 for, and slowly. And with Effexor, sometimes you even open the capsule and just use a little pellets so that you avoid that. These are the type of psychotherapies that we do. Meaning center psychotherapy was the one that I mentioned that is based on logotherapy, Viktor Frankl, with Men's Search for Meaning. If you read the book, it's a man that was 40 years, not 40 years. He was in Auschwitz for many years, and he rewrote his logotherapy when he came to the United States. It's part of existential psychotherapy. It's a great book, very small. And that book, it just gives you, what he says is like, life never ceases to have meaning. We just get disconnected from meaning at times. And so we work with our patients on meaning-centered psychotherapy. Dignity therapy, it's like a manuscript that you leave for your family when you want to just leave a story for your grandchildren. Then family-focused grief therapy, mindfulness, and more psychotherapy. And I think this is it. I can believe it took me an hour and 20 minutes. But I want to thank you all. Thank you so much. You can get connected with me at any time, of course. And I just ask you for one thing, just try to take care of your mental health. We are strong. That doesn't mean to be weak to go to a psychiatrist or psychologist. We all need that help. We all need a space to talk about things. And you don't have to have medications. But if you sleep better, you are better the next day, right? If you don't have pain, you feel like life is it's worth living, right? So thank you so much.
Thank you.
Yes, I think so.
Pardon me?
I think so. I think it was recorded.
Oh, okay.
We did record, we'll post it
Oh.
on the website.